Hey guys, my name's Sam and welcome to Prep Medic. This week's video, we're discussing diabetic emergencies, how to recognize them, how to check a blood sugar, and how to treat it. This week's video is sponsored by Medical Gear Outfitters. Medical Gear Outfitters is a family-owned medical supply company out on the East Coast. Whether you're looking for a pre-built kit that's plug and play, or you want to build your own, they have something for everyone. They've got great customer service and it's owned by Skinny Medic. So if you want to support a fellow paramedic, somebody that's been on this platform for a long time, you can go check them out. Link in the description. Let's get back to the video. Diabetes is a disease suffered by millions of people worldwide, and you have a pretty high chance of coming across somebody suffering from a diabetic emergency at some point in your life. So like I just said, this week's video, we're gonna go through how to assess a patient with diabetes, identify a diabetic issue, including checking a blood sugar, and then treating whatever might be going on. So while this will largely be a layman's explanation of diabetes, we do have to talk a little bit about the disease process itself. Now, keep in mind, there are a ton of different categories of diabetes beyond just type 1, type 2. Even within those two types of diabetes, there are a lot of subcategories and treatments are largely individualized per the patient. So take everything I'm saying and just understand there are exceptions to any rule I tell you. Now, diabetes essentially is the pancreas's inability to produce insulin. This can be from a variety of different reasons. And like I just said, you have two main types of diabetes we're dealing with, type 1 and type 2. Now, type 1 diabetes is the patient's pancreas cannot produce any insulin and they have to supplement with that in the form of an injection regularly. I remember this because one looks like a needle, therefore they're using a needle to inject it. That's just the little thing that works for my brain. Please feel free to use whatever works for you. Now, type 2 diabetes means that the patient's pancreas does produce a little bit of insulin, but not enough to regulate blood sugar and utilize the glucose within their vasculature. Like I just implied, insulin is a chemical that allows the body to utilize glucose. It allows the cells to bring in our blood glucose and turn that into energy. Now, a lot of our organs can go without a glucose supply for a prolonged period of time. However, certain organs, notably the brain, needs a constant supply of glucose to maintain cognitive function. That's why a lot of the symptoms we see in both hyperglycemia and hypoglycemia are going to be a decreased level of consciousness, along with some other things that we'll talk about as the video progresses. The normal range for blood glucose is between 70 and 120 milligrams per deciliter. Now, a lot of different texts will add a 10 or a 20 to either one of those numbers. Just know it's around that range. This means that anything over 120 milligrams per deciliter is going to be considered hyperglycemia. That's too much blood glucose. And anything under 70 milligrams per deciliter is going to be considered hypoglycemia. Generally speaking, a patient that has numbers slightly above normal or below normal is not going to have hyperacute findings. And we are talking about the acute setting and diabetic emergencies that you as a layperson can intervene on. That means that a patient that comes in at 150 to 250 probably won't have any symptoms from that hyperglycemia acutely. That being said, that hyperglycemia, if left untreated, can cause a lot of chronic conditions such as microvascular changes, cardiomyopathies, as well as some mentation issues. Same thing with hypoglycemia. That patient can generally get down to about 50 milligrams per deciliter before we start seeing an acute change in mental status. So let's talk about hyperglycemia first. Hyperglycemia generally occurs over days to weeks to even months in some instances and is very seldom a hyperacute issue. Hyperglycemia is the result of generally a patient that hasn't been diagnosed with diabetes. They cross that threshold and they don't even know they have it. They don't know that they're supposed to be checking it. They start developing these symptoms. It can also be the result of a diabetic that missed certain doses of their insulin, or in a lot of cases, a patient that's experiencing abnormal stress or a disease or sickness of some kind that has caused the breakdown of glucose into their bloodstream, and they have not been able to compensate correctly with their prescribed insulin. Regardless, these symptoms will generally start exhibiting in an acute fashion when they reach about that 350 mark. Now, at 350 milligrams per deciliter in a type 1 diabetic, we usually get into what's known as DKA, diabetic ketoacidosis. While this is most common in a type 1 diabetic, it can occur in a type 2 diabetic as well. like I said, just a little less common. So in these patients, they're going to start exhibiting a rapid rate of breathing. Now, these are generally called Cheyne-Stokes respirations, and it's the body's means of buffering that acidosis that is developing. They're buffering it by breathing out all the CO2 they have. You'll also see polyuria, so they're going to pee a lot, polydyspnea, where they're going to be drinking a lot, and this is essentially a osmotic shift in the patient's body where a lot of the water is being excreted, leaving them very, very dehydrated. No matter how much they drink, they can't replete themselves. They'll oftentimes be hot and flushed, and if you have an end-tidal CO2, it will oftentimes read low because once again, they're buffering for that acidosis. As hyperglycemia and DKA progress, you will get an altered level of consciousness where the patient will become confused and eventually they will be unresponsive. I will tell you, in my 13-ish years as a paramedic, I have never seen a patient totally unresponsive from hyperglycemia. When the blood sugar is increased above that 600 mark, we get into what's known as a hyperosmolar hyperglycemic state, or hyperosmolar hyperglycemic coma. This is generally more common in your type 2 diabetics. Its treatment doesn't really vary to what we're talking about today. Just know if you have a number that's greater than 600, if your glucometer even goes that high, that's generally what the patient is in. The personal highest I have ever seen a patient in is about 1,200 milligrams per deciliter, which is an astronomical number. I'm sure there are some nurses, ICU nurses in the comments that can tell me they've seen much, much higher than that. So our treatment in the pre-hospital environment for hyperglycemic patients is relatively limited. Like I just said, these patients are very dehydrated, so oftentimes a fluid bolus is necessary for them. With kids, we usually give 10 mLs per kilogram and just monitor for cerebral edema or pulmonary edema. And with adults, they usually get 1 liter to 1.5 liters before an insulin therapy is started. Now, in the pre-hospital environment, before we can get a full set of labs and have a treatment plan drawn out, we will not start insulin. We don't even carry insulin on the ambulances. The only time we use it is if it's a transfer from facility to facility. And this is because with an acidotic state, we have some transverse relationships with things like potassium. So as the patient gets more acidotic, you will have an increase in potassium. And if that potassium doesn't necessarily elevate and we start treating that acidosis, that potassium can plummet and we can kill them very, very quickly. Similarly, when we start messing with the osmolality of the patient's body, we can cause fluid shifts into the cranial vault, which can result in severe cerebral edema if we correct it too fast. So when we're correcting this, we do it very slowly, very methodically, and we have a chart with the insulin and the slow drip insulin we're giving, and we titrate that every hour on the hour to make sure we're dropping it at a correct rate. All of that is to say is we don't treat hyperglycemic patients very aggressively in the pre-hospital environment. Luckily, this is not a hyperacute situation. You can go the route of rehydration as you're getting them to definitive care. Just be aware that the potential for pulmonary and cerebral edema is there, and you should be monitoring them for difficulty breathing or a decreased level of consciousness. Let's talk about the opposite end of the spectrum, hypoglycemia. This is much more acute, and unlike hyperglycemia, we can actually do a lot in the pre-hospital environment, so it's not just going to be a buzzkill, I promise. These patients, when they start falling below that 50 milligrams per deciliter, will oftentimes have pretty profound behavioral changes. So severe agitation, confusion, lethargy, and it's not uncommon to find the patient completely unresponsive. When you're doing your assessment on an unresponsive patient, I always advise looking for some kind of medical alert tag to clue you into a potential medical issue like diabetes and hypoglycemia. For a patient that's responding to you but has signs of hypoglycemia, we can do the simple thing and give them sugar. Now, this is a very specific glucose packet that's made for diabetics. It just has a lot of carbohydrates in here, a lot of sugar to wake them up as fast as possible. But you can use anything from frosting to, I've heard rumors that Vermont EMS uses real Vermont maple syrup to wake up their diabetic patients. So literally anything with sugar works. I will say something that's a little bit more viscous will be a little bit more effective for your patients. So you can have them just eat a packet like this. You can have them eat a spoonful of sugar. It's going to work. But a faster route of absorption is to give it buccally. So what I'll do for these patients is I'll actually squeeze it in their gum, just like they're chewing some tobacco, and I'll put that all around their gum. That is a buccal route of absorption, and it's a little bit faster than just eating it. Eventually they'll eat it, and then the rest of it will be absorbed in the stomach and the intestines. This is generally only prescribed for a patient that is responding to you, that can protect their own airway. In a pinch, however, if you have somebody that's unresponsive, now keep in mind this isn't official recommendation, this is something that a lot of people would tell you not to do. I have known providers to take a little bit of this, put this on their finger and just start rubbing it on their gums. Just be aware of the potential of aspiration and be very, very safe with that patient. Once again, not recommending you to do it. So that's your oral glucose. Now, dose is kind of irrelevant. You're going to do this until they wake up. This is a 15-gram packet, which is pretty standard. If this is all you have, give them the 50 grams. Just know that it will take time for them to wake up. Usually you'll see significant improvement after 30 to 45 minutes with these patients. It can be longer. So it can be a relatively frustrating time to just wait for these patients to wake up. So if the patient is unresponsive, you can go a couple different routes. Most diabetic patients will get prescribed a glucagon injection. This is a special formulation that basically goes in an IM injection, intramuscular injection, that will start releasing stores of glucose from the liver. So a patient that is not routinely malnourished, this is going to work very well on, and lay people can be trained to do it. In these injections, you have two different vials, and you don't want to make a mistake here. So right here, we have these two vials, and this one has the medication in it. This one has the reconstitution fluid. You have to take the needle, draw up this fluid, inject it into the glucagon, twirl it around, get all that powder dissolved, draw it back up into the syringe, and then inject it into their shoulder or their butt. You cannot do this unless you are trained to do it. I have seen people untrained just drop this fluid, inject it into their arms, and nothing happened because they didn't actually give the glucagon. Again, this will take probably about 15 to 20 minutes for it to actually start working and waking the patient up. It's not like the movies. You don't just give the injection and it just works instantly. Glucagon is by prescription only, so this is not something you can just pick up at a pharmacy and carry in your kit. If you are an advanced life support provider or have access to IVs, you can go an IV route, which is probably the fastest way to wake a patient up. And this is going to be giving D50 or D10 through an IV. Doses vary depending on your patient. I usually titrate to effect and like going with the D10 just because it's a little less caustic than the D50. Know that if you're giving glucose in a vein, it is very, very caustic if it gets out of the vascular space. So you have to make sure the IV is patent before you start pushing it. Similarly, you cannot give dextrose in an IM injection. You can't give it right into the muscle because it will cause a lot of necrosis. Don't try to like make sugar water, draw it up in a needle and give it to somebody. So the last thing I want to talk about today is how to actually take a blood sugar with a glucose monitor. And any diabetic is going to have one of these. You can actually pick these up pretty cheap at pretty much any pharmacy. I bought this one at CVS today for about $18. And then the strips are a little bit more expensive if you're buying them without insurance. This ran me about $40 for 50 strips, and it came with the lancet to poke the finger. So like I just said, I've got everything I need right here. Only thing I would add is probably an alcohol prep pad if you're doing it to somebody else. I just wash my hands, they're pretty clean. I'm gonna, risk that infection for the video. So first thing I'm going to do is I'm gonna take a strip out of this guy right here and put it in the correct way. So you've got like this computer chip looking thing on one side, that's going to actually slide face up into the glucometer. They all work a little bit different, but at the same time, their operation is the same. So it's going to go through a bunch of numbers and then it's going to ask for blood. It's going to give you the little diagram to give it a drop of blood. I'm going to take the lancet. This one requires me to charge it. I'm going to hold it over their finger. I usually go with their ring finger just because it's still a beefy finger, but it doesn't have the calluses that some of the other ones do. And then I'll generally go off to the side of the pad of the finger. You want to press pretty firmly and then activate it. That's going to poke their finger, and you can kind of, I call it like milking the finger. You kind of get the blood down, get a good blood drop there. Make sure it's big enough. Now I'm going to take the glucometer and I'm going to dip it in the blood until it fills up. And now it's going to calculate the blood sugar right here. So it comes back and I've got a blood sugar of 90 right now, which is right in the normal range. There are a couple limitations to glucometers that we should talk about here. Number one is that they have a pretty wide acceptable range. So we test these with test strips and they're supposed to come in at a very specific range on blood glucose. We're essentially putting sugar water in there instead of blood. And the number one test solution has a viable range between 21 and 51 milligrams per deciliter, which means this has a potential error rate of about 30 milligrams per deciliter. That's the difference between the patient being, 80 and potentially being 50. So take the readings with a grain of salt and always treat your patient, not necessarily just the number you see on here. When in doubt, I'll generally take 2 if I'm getting kind of weird numbers that don't correlate to what I'm seeing. Number 2 is these are very sensitive to temperature. So if it's really hot outside or really cold outside, they can give you inaccurate readings. And lastly, these have a range they can provide numbers for. I don't actually know what it is for this one, but generally when you start getting beyond 500 milligrams per deciliter, this will simply read high. If you go much below 30, generally this will just read low. So like everything, just know your limitations and know how to work around them. I hope this video is helpful and not too confusing. If you have any questions, leave them in the comments down below, and I will see you next week.